Hello and welcome everyone to today's ASIPP webinar, Comprehensive Physician and Practice Resuscitation Training. At this point, I'd like to pass the floor to our first speaker, Dr. Laxmaya Manchikanti. Dr. Manchikanti, if you're ready, the floor is all yours.
Thank you, Trevor, for a great introduction here. There are many people attending this. This is going to be a special day. I would like to thank all the attendees and all the speakers. It is going to be an exciting webinar. We are going to do this somewhat differently today. Our first speaker is going to be none other than Kevin Foe. All of you know it is Kevin MD, and Dr. Devi is going to interview him. We need to go ahead and finish this, so he has other appointments and go. Dr. Foe, we are very grateful for you for accommodating this, and we will get you out on time. Thank you. Dr. Devi, go for it.
Okay, great. Thanks, Dr. Manchikanti. So Kevin, thank you so much for this honor. I'm really excited to be able to interview you. I've been a follower of yours for several years. Can you tell us a little bit more about your journey as a medical journalist and a publisher and what brought you to this point?
Well, thank you so much for having me. I'm really excited to be here. I'm an internal medicine physician. I'm in Nashua, New Hampshire, which is about 45 minutes north of Boston. I've been practicing for 20 years now. And as you know, I'm the founder and editor and owner of KevinMD.com, which is a social media platform that I started back in 2004. And at that time, it was a platform really to interpret and answer patient questions and what they read in the news and what they read on the internet, because as everyone knows, a lot of online health information isn't always the most accurate. And it's evolved into a platform not only on the website itself, but also on Facebook and Twitter and LinkedIn, where physicians can really share their stories and have their voices heard. And I'm sure we're going to talk about this later on. I think it's tremendously important, not only before the pandemic, but especially now during the pandemic. It's so important to share our stories and have platforms where we could be heard, because mainstream media platforms, they are not really edited and controlled by physicians. So it's important that we have our own platforms and really showcase our stories.
So let me tell you a little bit more about ASIPP. We represent pain physicians, and some of the challenges that we have right now are that, in terms of our patients, it's very hard for them to get their pain managed. First of all, they have multiple medical problems in general. For their musculoskeletal issues, they can't really see physical therapists at this time. There are concerns about NSAIDs. They can't have nerve blocks and other outpatient elective procedures. And on top of that, a lot of them struggle with depression, anxiety, and insomnia, even otherwise. So they're becoming more frustrated. And then meanwhile, us as physicians, a lot of the members of ASIPP, they're small business owners to begin with. So from a business perspective, are there things that you can see that we can do right now to prepare us for the other end of this, at least to make our businesses maybe stronger, to encourage our patients to kind of carry through this and then come back to us when we're on the other side of this?
Sure. So I think that a lot of the issues that you just said, it's really applicable to a lot of private practice physicians that are out there. I talk to a lot of primary care doctors, and they're in private practices, and they, of course, can't see patients face-to-face in the office, and the revenues are down 50 to 70%. A lot of them have switched to telemedicine and virtual visits. In my own practice, it's pretty much 100% virtual visits, a combination between telephone calls and video platforms. And I could probably take care of 70 to 80% of my patients that way. But I think it's very, very hard, because this is moving so fast, because the rules are literally changing as we speak, especially in terms of reimbursement. And I really sympathize with a lot of private practice physicians. I know a lot of them have to furlough their staff, and I hear stories about how physicians themselves, they can't really stay in business, and they have to shut down during this pandemic. So I think that what we need to talk about is a transition to virtual platforms. I think that both Medicare and commercial insurers are trying to pay virtual visits at the same rate as regular E&M visits, and I think that we need to do our best to transition to that. On social media, I'm involved with a lot of private Facebook groups, physician-only Facebook groups, and they really share a lot of their stories and tips on how they can manage the situation going forward, and sharing their stories about what goes on behind the scenes. I think that what we can do is, as a whole, is that we need to let the public know that some of the difficulties that we face. I think that there's a lot certainly going on, not only with the pandemic, but I think there's a lot of hidden stories as well, and namely some of the stuff that you just said regarding the difficulty financially maintaining a practice, and doctors taking pay cuts, and having to furlough nurses. And I think a lot of these unreported stories is something that we can speak up with on social media, whether it's through a blog or on Facebook, because we need to let not only patients know, but really politicians know, because these are things that not only affect our lives, but the lives of our patients as well.
So do you think, just as a follow-up on that, for individual practices, should they reach out to their own patients or let them know this, maybe through their website or through some other contact with them? Or do you think, more as a general principle, we should be advocating for ourselves?
I think both. I think on a practical standpoint, I think that we need to do our best to transition to some type of virtual platform. I know a lot of us in primary care, we're pretty much 100% virtual, and I know pain physicians themselves, I guess there's no choice, especially with the pandemic. It's hard to see patients for routine visits. And then I think from a broader perspective, we do need to advocate for ourselves too, because there are so many issues that are simply not well known. And, we touched briefly on, the financial aspects, but I think there's also like a liability aspect as well, because we're not seeing patients face to face. And I think there's a liability risk as well by not doing that. From my primary care standpoint, I'm not ordering mammograms, I'm not ordering colonoscopies, and I think there's a liability risk of not doing these things, especially during a pandemic. And who's going to protect us from that point? And I'm sure from a pain management aspect, if you don't see patients regularly, if you prescribe controlled medications, you need to see patients face to face to see how they're doing, and you can't during the pandemic. And I think there is a liability risk to that too. So I think these are issues that aren't often reported, and I think that's something that we do need to advocate for ourselves, because really no one is looking out for our best interests but ourselves.
I agree. On the subject of advocacy, I'll just say I agree with you completely. I mean, we have patients who are on opioids, and so that's, one issue that if they were on it before, maybe we can follow up. But if they weren't on opioids before, what do we do when they've exhausted some of their other options? And same thing, if they have pain, generally the best treatment is to try to treat the cause of the pain. But if you're not able to get studies to find out if it's something dangerous, you're also kind of in a tricky position. I have joined a bunch of Facebook sort of private chat groups as well, and some of the things that I saw on there, not just pain physicians, but all healthcare providers, I've been seeing things about people being forced to work in unsafe conditions. They don't have adequate PPE, like we saw the pictures of nurses in garbage bags. I've heard a lot about pain physicians, especially those who are anesthesiologists, kind of being mandated to volunteer on other units. So it's a, two-way street. Like if it's your expertise and you're just volunteering in a different capacity, it's one thing. But if you're literally forced to volunteer or work for free, that's sort of a different thing. A lot of people are being forced to accept pay cuts. So even if you're a hospital employee, you're in an elective procedure area, furloughs, unpaid leave, and then also people sort of shifting costs so that maybe they now have to pay more for their malpractice premiums, whereas the hospitals would pay it before. I mean, I'm just wondering, these private chat rooms seem to be individual groups, and if you happen to know someone who has a chat room, then you can join. To be able to, for doctors to be able to advocate for themselves in these scenarios.
Sorry, I missed the last part of your question. You're cutting out. Can you just repeat that last question?
Oh, I was just asking, do you see a more organized way that doctors can advocate for themselves? Because in these chat rooms, I see doctors telling other doctors about their problems or other healthcare professionals, and there's a lot of empathy and sympathy and camaraderie, but sometimes there's not that much in the way of practical solutions, especially because of concerns about HIPAA, restrictive sort of media policies that a lot of these hospitals have. and sort of the public perception that doctors are kind of, supposed to sort of do these things out of altruism, and that they generally make too much money, so they shouldn't have to worry about these things.
Yeah. So, that's a fantastic question. So, the question is then, how can we advocate for ourselves, and what are some of the measurable impact of doing so? So, number one, I think, is what I mentioned before, sharing stories. Certainly on my site at kevinmd.com. Since the pandemic started, I've shared over 400 clinician stories. Some of them they got shared over 1 to 2 million times, and they themselves got traction with mainstream media. One of the things that I do is really act as a bridge from social to mainstream media. And a lot of the authors, the physician authors on my site, they get contacted by newspaper editors and television producers, and they appear on CNN. So really, it acts as a springboard to a larger platform where they can share the stories about the lack of PPE and the fact that physicians are being forced to practice in areas that they're not comfortable with. I certainly think medical students and residents, for instance, they don't have any voice, and they're being forced on the front lines as the initial soldiers, the proverbial soldiers of this fight, and they don't have a voice at all. And I think that, to me, is also a tragedy. So just sharing your story and being heard and connecting with the public and letting them know about what's going on behind the scenes is tremendously important, because hospitals, you may have read, are silencing healthcare workers who speak out, and to me, that's completely wrong. So the second part to your question, what are some measurable impact? Well, there is there's a radiologist, some of you may know, Dr. Nisha Mehta. She runs the Physician Side Gigs Facebook group. So she and her team has created the COVID-19 Pandemic Physician Protection Act, the CPPPA. So if you go to change.org and search for that, it's the COVID-19 Pandemic Physician Protection Act. It's a act that is working through Congress. It's being introduced to House of Representatives. There is a petition on change.org with 232,000 physicians who signed, and they talk a lot about the protections that we have briefly mentioned here about the lack of PPE, the fact that our physician practices are failing, the fact that there is no liability protections for some of the things that we are doing, and these are things that certainly have not been addressed, and attention needs to be brought to them. So in terms of organizing physicians on social media, that is just one example of how online communities are banding together and not only making our voice heard, but hopefully making some change as well.
Do you see, Congress as the main method for kind of advocating for ourselves in addition to social media? Because I can see a lot of conflict between the hospitals and sort of private practice groups, because the hospital, everybody's focused on because they're the ones treating the coronavirus patients. But at the same time, physicians, sometimes there's a tremendous conflict between what the hospital wants and what the doctors want. And especially if you're in the category of elective procedures, I think you get kind of pushed to the end of the line.
No, I think that's completely true. I think one thing that we're finding out now is that hospitals and healthcare organizations, they do not have our best interests at heart. And to me, that's such a stark reality, especially you're hearing administrators silencing physicians, especially early on when, before we knew about how contagious COVID is, they would tell physicians and nurses not to wear masks around patients, and they would fire physicians and nurses for speaking out against the lack of PPE. And these are things that we'll always remember. And now we know how serious this pandemic is. And I think that some of the things that administrators and hospital systems have done to physicians, to be frank, it's unforgivable. So I think that we need to not only advocate for ourselves, we need to take care of ourselves. And that's really by banding together, advocating for what we need, making sure that we're protected, especially in the midst of furloughs and layoffs, and in the future, potential liability for not only the services that we're not doing, but if we're forced to do services that we're not comfortable with, there already are malpractice lawyers out there asking questions saying, hey, why are you managing an event this way? And they're not going to really care that you haven't done it in 20 years and you just got trained on it. So I think that these are all questions that we need to ask. Of course, patients should come first, but we need to take care of ourselves first. And I don't think that we should sacrifice that and blindly just go forward without knowing these risks.
Well, thank you. I know you have to leave, so thank you so much for all that you're doing to kind of help healthcare providers and to fight this exploitation, and for sharing your thoughts and your time with us. So thank you so much.
Thank you, Kevin.
Well, thank you. Thank you so much. Thank you.
Thanks. Okay, now we are going to go to overview. Before we get started, I would like to thank Boston Scientific for partial support of these web COVID seminars, etc. They funded us. They are the first ones who gave us some money. We also sent you a COVID burnout survey. You got in a few hours ago or an hour ago or so. We can go ahead, if you go ahead and fill it out, that will give us a lot of information in reference to how much we are suffering, and we can actually take it to the Congress and administration to show our issues. What we are doing is comprehensive physician and practice resuscitation. It is very similar to CPR. It is just a little bit more intense, I think, because we are not the patients there. Here we are the patients. So we have still issues with social distancing. Right now, we don't even know how long and how much. Is it still 6 feet or not? Everybody is telling me 6 feet, but it will be hard to run a restaurant with 6 feet, people sitting across. Wear a mask and facial cover, wash hands, telemedicine. Beyond June 6th, what is going to happen after that? Infection control and sterility for patients, staff, and physicians. We are still struggling with steroids. Chronic pain itself is a risky thing for COVID. So because of the immune system and various other issues involved with it. Now, with all this, our insurance premiums are going to increase for public. At the same time, they are going to get reduced coverage. They're expecting that 41% increase in insurance premiums, also reducing reimbursement with increasing overhead. Essentially, we are in a financial reckoning too. Resuscitation, this is our phase, and we are going to get to rehabilitation hopefully soon. But we don't know how the final product will look like. So we heard that on CNN, they gave a negative spin to this, what happened yesterday. A lot of people are pretty happy about it. And for New Yorkers and New Jersey folks, I feel sorry for them. They are locked down for another 2 weeks extra. So Trump completes reversal, telling governors, you're going to call your own shots. The Wall Street Journal gave a not so positive, not so negative, but it is real, actual, the way things are going. Now, there are 3 phases to what he has told: to mitigate the risk, protect the most vulnerable, but they have to have up-to-date data. And they can do this statewide or even county-wide. So we don't have to close down entire country or entire state. We continue to adhere to the state and local guidance as well as complementary CDC guidance, particularly with respect to face coverings. Employees, they have given significant guidance. Employers, guidance. Specifically, some of those things are important. Schools and organized youth activities, these are very important. In phase 1, they still will be closed. So phase 1 may last a week or 2 weeks or 6 months. But we can start doing elective surgeries. If we consider interventional pain management techniques as elective, they are elective and they are surgeries. It all depends on everybody's definition, but we do them many of the times in surgery centers and hospitals, also in the offices. So they are surgery procedures. These are outpatient procedures. So it also says that adherence to CMS guidelines. CMS guidelines, I'm not quite certain what it means. There are no CMS guidelines for office procedures, not that I am aware of. Some states do regulate office surgery procedures, but there are no CMS guidelines. For surgery centers, they do. Hospitals, they do. That is a little bit confusing there. I just now saw this joint statement from American Hospital Association, College of Surgeons, American Society of Anesthesiologists, and AORN. They're all talking about hospital outpatients only. No one is talking about office procedures like the one we do or the procedures we do in surgery centers. They defined vulnerable individuals as all elderly, individuals with serious underlying health conditions, including high blood pressure, chronic lung disease, diabetes, obesity, bronchial asthma, immune system compromised by chemotherapy for cancer and other conditions. Phase 2, once we decide that they are ready to go into the phase 2, again they have for individuals and for employers. This is where the daycares, camps can start opening. At the same time, elective surgeries can resume. They already resumed last time, but they can also start doing inpatient basis. That was only outpatient so far. Now it becomes inpatient. Phase 3, it is pretty much to normal. Everything, people can go and visit each other and bars will open and everything else goes to usual. We have had 3 webinars. This is the 4th one. These are all recorded versions available at ASIPP.org. And you can also communicate with email with any of the ASIPP members. And LinkedIn, all the social media, Devi and them were talking about a few seconds ago. Next webinar is on Thursday. As we proceed to further, we are going to try to get back to normal. We have more and more lectures concentrating on how to get back to normal. We were in resuscitation phase still, but now we are going to move towards rehabilitation phase. We are also going to talk about revenue cycle management, how to form an IPA, and marketing during recession. This is where we are getting into rehabilitation phase. This is the last one we are planning on Wednesday 29th, unless we need to do more of these. Again, these are going to focus on multitude of these, and you need more information. You just heard Devi. She wrote this nice, wonderful book, and look at that pretty picture there. So we still are working on these things. We are trying to postpone telemedicine, telehealth through August 6th. I haven't heard from them. We have been writing to them. It is not only for all Medicare and governmental services, but like private insurers too. So we are asking Secretary Azar to look into this along with Secretary Eric Hargan, Deputy Secretary. On one aspect, Seema Verma has agreed that they will extend our repayment period from 90 days to 180 days. And after that, they will extend that also for 180 days instead of 90 days. So we were going to pay it off in 6 months. Now you have 1 year to do this. They're looking at the legal aspects of it. We don't have the information on that yet. So we also had multitude of guidelines. These are from ASRA, and the same thing was published by a few others. Cohen et al., they published the same type of, pretty much the same guidelines. There may be some differences, but overall, pretty much the same. These are almost like past. They're not really going to tell us how to get into the present practice and practice into the future. So ASIPP has a task force on this. It is headed by Shalini Shah, and there are many others involved, Dr. Devan, Amol, Sayan, and Christopher Garibo, and others. They're going to come up with an approach and a risk stratification to decide what type of patients we should be doing and what kind of risk they fall into. Like during all May, we are hoping that we'll be open on May 4th. So we are going to do only low risk procedures. We are putting out other ones to a higher outside. The same way, they are going to have a question answer session, description, and recommendations practical recommendations to further practice. We are not producing guidelines or position statements. We still continue to go through these audits and investigations. I'm still getting these things, LCDs and a lot of guidelines. So we are working with Seema Verma again to postpone these, at least suspend them during this crisis for 6 months. Same thing with Secretary Azar about all other private insurers. Now, there is a hearing or multi-jurisdictional CAC on facet joint and medial nerve branch procedures. The people who are on the evidence panel have received invitations. Same way, each and every CAC member can sign up and go ahead and be able to speak if you sign up. So you have to go ahead and to the website and sign up. And for anyone else, you can all sign up. You may not be able to speak. It depends on their availability, but you will still be able to listen to it and participate. Number is significantly important, how many people sign up. These are the consensus practice guidelines. I'm not sure they are looking for consensus. They are looking for evidence base. Coming back to our charts here, so we use the hammer approach. I look at it as from 3 to 7 weeks up to May 3rd, except for New York, New Jersey, and some of the states. The hammer has worked. Now we are going into the dancing phase, starting from May 4th. These are again the cumulative cases per 100,000. If you look at the charts, it really looks bad. Now, when we started this, our first webinar was on March 27th. When we decided to close our offices was on March 16th. There were only 60 deaths on that day. By the time we had the webinar, it was 1,300. Today, it is 35,000. But USA is still not number one. They keep saying that it is most deaths. Its rank is 7. If you take total cases per 1 million or total deaths per million population, it is 105 deaths per million population. There are many others who have a lot more than that. This is New York, New Jersey. They are in pretty bad shape, especially New York, followed by New Jersey, of course. California is doing very good, but it looks like they're already going to extend their lockdown. New Jersey, Illinois is a much smaller state compared to California, but they are locking down, and we are hoping Illinois will open. So again, we keep saying that mortality is highest in the United States. It is not really. US death rate is about 4.1. Belgium is 12.8. Italy is 12.8. UK is 12.7. the global death rate is about 6%. So whether we admit or not, I think they have been doing a very good job with mitigation, but it is causing a lot of problems. So we also need to count the deaths from the shutdowns, not only from corona, but with the shutdown itself. The suicide rate has been increasing substantially. In 2017, there were 40,000 or so suicides. But with increasing unemployment, with 1% increase in national unemployment, the suicide rate would rise 4.1%. And total mortality for the country would rise by 2%. What this translates into is there will be about 70 to 77,000 more deaths because of the increased levels of suicides, either by any means, including the drug overdoses. This is apart from regular drug overdoses. Drug overdoses are about 42,000 or so. All drug-related deaths are 68,000 or 70,000 total. It is coming down quite a bit. If you take prescription opioids, it is like 15,000 or so. Even motor vehicle accidents are more than that. Now, this itself is going to create 70,000, 77,000 deaths. So what is worse is the issue. So now we come into the testing and treatments. We have this so-called evidence-based medicine, and we have been arguing about this for years and years. What I say works for somebody else, it doesn't work. You can switch or twist the evidence any way you want to. It is the same story as the parachute. Parachute used to prevent death and major trauma related to gravitational challenge. A systematic review showed that the basis for parachute use is purely observational, and its apparent efficacy could potentially be explained by a healthy cohort effect. But we also know, based on this so-called evidence-based medicine, everything has been overdiagnosed. Now, diabetes, the sugar was 126. From there, we increased it to 140. From 140, it went down to 126, then to lower, and now it's only 99 or 100. Now, there are so many people who are diabetics because of that. Hypertension, hypercholesteremia. The statins cause so many side effects. Nobody can prove that they're beneficial, but we still people still keep taking a lot of statins. This is the latest, I don't have time to go through all the articles, but the latest one in New England Journal of Medicine, it says that there is no difference between conservative strategy or invasive strategy for stable coronary artery disease. This modest mean differences favoring invasive strategy, overall group reflected. This is another study in the same journal. This is something interesting for us. It talks about the steroids, physical therapy versus glucocorticoid injection for osteoarthritis of the knee. Guess what? They're saying physical therapy alone does better than with steroids. With regards to the treatment for COVID, there are about 400 ongoing trials. Many of them are repurposed drugs. There are about 40 new drugs and investigational drugs. So hydroxychloroquine for COVID has been a major issue. Everybody has been talking about in favor and against it. So there is no randomized controlled trials to satisfy everyone, even though there are. And they are all calling it anecdotal evidence. This is 100 patients studied. They all showed improved radiologic findings, enhanced viral clearance, reduced disease progression. 36 patients in the treatment group, 16 patients in the control group, enhanced viral clearance. Addition of azithromycin was superior. Another study, 30 patients in each group, reduced disease progression, reduced mortality, but there was no change in the viral load. So they interpreted this as a negative study. When you combine hydroxychloroquine plus azithromycin, it could be a dangerous combination because they both have effect on QT interval, but it still appears to be insignificant in spite of all this drama here. It all depends on how long you take it and what your dosage is. You can calculate the risk factors. This is the same type. We are trying to develop risk factors or look for risk factors before we do interventional techniques. We are also working to get approval for expanded umbilical cord mesenchymal stem cells. We are running into a lot of roadblocks. There are no studies on exosomes, but we are also trying to get that approved. We are working through many channels. So our goal is to keep you informed, safe, scientific, and secure, and move slowly, steadily, rehabilitate. So find something you're passionate about, stay calm, be well-rounded. So we want to ask you some questions. Trevor, do you want to take over here?
Absolutely. On your screen, you should see a polling question appear momentarily. The first question, have ASIPP advocacy, information, and financial activities been helpful? Please select yes or no. We'll give everybody about 20 seconds to fill out this polling question. We'll have a couple more coming up after this as well. Okay, very good, very good. And the next polling question that you'll see momentarily, are you interested in future webinars? Yes or no? You should see this on your screen in just a few seconds, just like the first polling question. We have one more after this. We'll give everybody about 15 more seconds to fill out this polling question. All right, very good. And now the third polling question you should see on your screen momentarily. Have you registered to participate in multi-CAC process? Yes, no, not interested, or not eligible? Thank you all very much for your responses.
So, like Paul Harvey used to say, now the rest of the story. Amol is going to talk next, and after that, Emily Yoder from CMS is here. She will be answering our questions. Next one is about testing for coronavirus and antibodies. And after that, we will discuss about insurance issues. And then we will go into a discussion panel. And here is Amol about financial overview. Amol?
Yes, hello. Thank you, Dr. Manchikani, and good afternoon, everyone. Thank you again for giving us your Friday afternoon. Again, we're going to go over some highlights and tips and updates on the business and economic impacts that we have been seeing. And as I've mentioned before in these webinars, ultimately, obviously you are responsible. What I'm presenting is just my opinion, and it's important to consult with a lawyer, a banker, or an accountant. Something happened last week, right? We got that HHS stimulus check or deposit, or at least most of us did. To some people, that was a surprise. I know to Dr. Manchikani and some other people at ASIPP that had been working with and talking to HHS, that was not a surprise. In other words, they knew it was coming. What it ended up being was approximately a 6.1% bonus or incentive based on your previous year Medicare billing. It was a direct deposit into the account, assuming you use EFT with your Medicare billings. And it was part of the CARES Act. That initial $100 billion that was actually set aside for hospitals, $30 billion of that was carved out and given to providers of Medicare services. There is some action needed. Even though a lot of people didn't even ask for the money, it just showed up in your account. There was a big uproar after that got released to various people. For example, there are some counties or areas which at the time had a very low prevalence of COVID-19, and some providers were in areas that really didn't have any in their county, for example, in some rural health areas, but they still got the stimulus check, and that caused some problems. So they made some adjustments, and now you have to do an attestation theoretically, in order to keep the money. Although I don't know how they would claw something like that back when it was given to people without necessarily asking, but there is an attestation needed. And to do that, you should have gotten an email, but I know how a lot of practices are, and sometimes the email goes to an administrator, and you guys as practitioners may not know what to do. So there's a link that you go to, and it's here on the bottom of this slide, covid19.linkhealth.com. You can actually go to that. It doesn't take very long to complete your attestation. When you go to the link, there's a couple of steps of a process that you have to do, and that's here on this slide. There's basically 4 steps. And the first step is just a yes or no question or answer, asking, are you eligible to actually receive the stimulus money? And that is, are you a provider of Medicare, basically? And are you still in active practice, essentially? It's just one yes or no question. And then you hit that and you move on to step 2, where you have to put in your billing tax ID number for your practice or your ambulatory surgery center or whatever entity got that stimulus check. In addition to your tax ID number, you actually need to know the last 6 digits of your account that you have to put on there, and you actually have to list the dollar amount of your stimulus check there, and that's step 3 to verify payment information. Then you move on to step 4. And there's just 2 yes or no questions that you have to answer. If you want to keep the money, the answers to both questions are yes. That is, you are treating patients that basically potentially are or could have been or may be infected with coronavirus. The HHS has provided clarification that they said they believe that if you have treated any patient, you can assume that they potentially could have coronavirus, so that you would attest yes to that, and then you would attest yes that you received the money. And then it moves on to a confirmation page. Literally, if you know your tax ID number and the amount of money you got in, it is a 5-minute process or less. But please do complete that. They gave you 30 days to do that. And as I mentioned, the website's on the bottom there, covid19.healthlink.com. And we know about the other financial incentive programs, but just to go over them briefly, I know a lot of you guys probably already know about these, but the Medicare Advance Payment Program, is still out there. Interest-free bridge loan type of a program that you can apply via one-sheet paper to your MAC contractor. There's that SBA disaster grant, that $10,000, although very few people have been funded out of that grant. Because it was such overwhelming response, they made a change in the payment algorithm, because before they were offering just $10,000 and they said that you would get it within 3 days from applying. But they have subsequently changed that payment to $1,000 per employee, saying that the demand was so high. But just a random straw poll of several of our colleagues in Ohio and friends, I only know of 1 or 2 people that have actually gotten anything from that, despite the fact I know a lot of people have applied. Hopefully, some of you who applied early are one of the lucky ones. We all know or probably have heard about the SBA PPP loan that is out of money as of Thursday. Unless you have a loan number with the SBA, at this point, you will not get funded. There's like this ETAN number that you get when your bank actually sends the application to the SBA. If you did get one of those numbers, because all the funds, even though it's out of money, all the funds haven't necessarily been dispersed yet. So if you actually got one of those numbers and you haven't gotten the money yet, there's a potential that you will get funded in the next couple of business days. However, if you did not get one of those numbers, it's probably safe to say that you won't get it. Some banks said that they're going to keep your applications on file in case Congress passes further relief. Potentially they will do that. There's debate whether or not it will happen. But with the talk of the economy reopening in phases and the fact that there is still some political debate between Republicans and Democrats and some gridlock, that's still up in the air. There's 700,000 SBA applications that did not get processed. And that number may be higher, but those are active applications that were in queue that the SBA knows of that didn't get processed because they ran out of money. If they were to re-up this package, so the first round of the package was $349 billion. And so $1 billion is actually a very large number that you all know. And $349 billion is an even a larger number. So let's just say, for example, they re-upped it with $350 billion, that would be approximately $500,000 for each of these $700,000 businesses, assuming that every dollar went into that particular application, which is still a very large number. So we'll see if it gets re-upped, and if it does at that amount, that might still be available for us. It's interesting to see who actually got the money. We noticed some trends in reading for this slide presentation. I was noticing some trends. Obviously, smaller regional banks that were able to operate more nimbly were able to get the money out. But interestingly, most banks picked businesses that had large loans with that bank. And part of that's because that bank, that loan that they give to that business, that's their money that they're giving, and they don't want that client to default. So it's in their vested interest to help that client get as much money as possible so they can recover their actual loan. And so we saw some interesting things happen. Ruth Chris Steakhouse, right, got $20 million from this coronavirus aid program. And they were one of the first to disclose that SBA funds were received under this federal rescue package. Now, they have something like 5,000 employees. They have multiple restaurants and stuff. But, they also carry a high debt burden with various banks, to build out their physical locations and et cetera. And, the bank doesn't want to get stuck with a toxic asset. So, when they're looking at their clients to service, given that there's so much demand, they're obviously going to, work to protect their own interests as well, which is what we saw with this loan. So now we're going to be, at some point shifting focus to return to practice. To some extent, it's time to move on and start looking forward. And so a lot of questions remain, right? When to resume procedures, when to start practice, how to manage staff and employees. What happens if a staff member tests positive for coronavirus? What happens if you test positive for coronavirus in the next couple of months? What do you do? What about staff who are laid off and now they don't want to return? Do you fill their position? What do you do with them? How to make sure that you and your patients are safe going forward, like what kind of guidelines you can have in your practice. These are a lot of questions that we're going to have to answer as far as return to practice. So in order to do that, Dr. Manchikani had commissioned a small work group led by Shalini Shah that you may have heard of early on. Chris Garibo and Sudhir Dewan, myself, and some others are working on this this document. What we're trying to do is provide, some guidance and algorithm and maybe some guidance statements that would be helpful for you all as you move forward to return to practice. So hopefully we'll be able to deliver a quality product for you guys soon to answer some of these questions. One other thing I want to mention just before I turn it over is just the importance of ASIPP and what it does for you, because, a lot of people may not realize how integral ASIPP is in doing things, because there's a lot of medical societies out there. But when it comes to securing your best interests financially, ASIPP was right at the forefront, dealing with HHS, trying to get that stimulus money to you all. As I mentioned, Dr. Manchikani was discussing with the HHS and sending letters to people about this even before we all knew this was coming. It's something to think about as you are looking at, various societies advocating for you, that ASIPP is really right there and has your best interest in mind. So I will move on to the next speaker, and I'll turn it back over to Dr. Manchikani. Thank you.
Thank you, Amol. Now we will go to Emily Yoder. She is an analyst in the Division of Practitioner Services in the CMS Center for Medicare. She has worked on Medicare physician fee schedule rate setting and policy development since 2015, including primary care, evaluation and management visits, communication technology-based services, and Medicare telehealth. So there are two important issues for us here, that is evaluation and management services as well as telehealth. That is the burning issue now. Please send questions so she can answer them. Our major question, Emily, can you hear me?
I can, Dr. Manchikani.
Thank you. Most of our issues are related to the telehealth, specifically different payment systems and different policies. In the beginning, we thought phone only was available, and it was billed at 99212 to 99215, and we have been billing it as such. Then suddenly, Shalini, we are referring her name quite a few times now, she said, other day she showed me that it was not covered, so that is when we contacted you, as well as Seema Verma and others. So that is the major issue for everyone. Probably you don't have an answer for that yet. Would you comment on it, please?
Yeah, we have definitely heard that this is an issue from ASIPP as well as other stakeholders. I understand why it is very confusing. We've been moving really quickly to try to introduce as much flexibility as we can. However, the baseline Medicare telehealth rules, many of them are still in effect, and so for office outpatient E&M furnished via Medicare telehealth, the technology still must be two-way audio-video telecommunications. We did, in an effort to sort of address the fact that many Medicare beneficiaries might not have access to two-way audio-video or may choose not to use it. That was why we activated via interim final rulemaking the telephone-only visits. And it's very confusing because they're visits, but they're not on the Medicare telehealth list. And we're looking into additional flexibilities that we could pursue to expand access to telehealth services for beneficiaries and practitioners for whom audio only is the technology that they prefer to use.
So you do understand that the significant problem, especially in Paducah, people ask me what country is that in, so people don't have telephones in this area. That itself is a difficult issue. Just having a regular phone is pretty good. In St. Louis, they say, one of my friends, he says all his patients run out of their minutes first week, so they don't have anything else to do after. So they're all coming into the parking lot and standing there. They're trying to put some telephones there so they can pick up and call from there. Once we put that, we have been trying to do this audio-video combination. Our access rate to patients is like 20%, whereas if you do only telephone only, it is almost 98 to 100%. So it is really advantageous. It is much better. Otherwise, people will just go on to the street and start buying the medication, and then we will have this another fentanyl epidemic. It will be worse than corona epidemic. So hopefully it will all be considered soon. I have a question here. It is pretty much the same what we have been talking about. How do we build telemed visit to Medicare, getting different information from different webinars? One is EM 99213, facility 11, modifier 95. Second is EM 99213, facility 02, no modifier, which is correct?
So the first one is correct. You would bill the E&M visit, the facility, the place of service code where you would have furnished the visit had it occurred in person, in this case an office, and then the modifier 95 to identify it as Medicare telehealth. Place of service 2 was how we identified telehealth services in under the sort of non-pandemic situation, but as practices were, and it pays at the place of service 2 pays at the facility rate, that for services where there's a site of service differential, the facility rate is the lesser of the two payment rates. And so what we wanted to do as by recognizing that more practices are going to be moving to virtual, more virtual types of services, and recognizing that there are resource costs associated with making that transition, we wanted to make sure that there was payment stability between the kinds of payment rates for office visits that you would be getting prior to the pandemic that were not furnished via telehealth, and the payment rate that you would get now that you were furnishing the office visits via telehealth.
There is a question. This is from the doctor who works in a hospital setting. The question says, hospitals are telling doctors because they cannot bill the facility portion of E&M during telemedicine, therefore they are discouraging it. I just talked to a nurse practitioner, and they furloughed him, actually. Not only discouraged, but furloughed him.
That is very unfortunate. We've heard a lot about this issue, and we're working to address it. Hopefully there'll be some good news soon.
So next question is, just to verify, Medicare is requesting POS 11, place of service 11, for telehealth visit with a modifier of 95. Do they need a POS 11 and modifier 95, or?
You need the modifier 95 and then the place of service where you would have furnished the service had it occurred in person. So in many instances, that will be place of service 11 because that's the office setting. However, there may be additional places of service that could be added to the claim as well. Place of service 11 is the one we've been using as an example.
The next question is, TRICARE Humana Military rejected claim submitted with POS 11 and asking provider to resubmit with POS 2. Your thoughts on it?
Unfortunately, I can't speak to TRICARE's policies. The place of service 11 with the 95 modifier is a Medicare-specific policy.
Okay, another one of my friends wants to know, all of my virtual check-in EOBs have been denied G2012 site of service 11.
I'm sorry, I have to ask a question. What is an EOB?
Oh, EOB is the explanation of benefits.
Okay. Sorry. So I am not sure. I would need to have this question sent to me in writing so that I can look into it. EOB is not something that I'm familiar with, as you can tell.
We don't need to use virtual check-in, right? You just use the code you used. Why do we need to use virtual check-in there? I'm not sure. My friend understands this. So, and denied G202, that may be the code they are using for denial, but they have to use whatever the code, like 99213 or so, and 11, right, and modifier 95. So.
Yeah, if he wants to send that question to me, I can try to get it to the right part of the agency. And maybe if he provided a little bit more information, that would be helpful too.
Okay. Another question is that what other issues you have faced from interventional pain docs in particular and other docs in general about these telehealth issues?
So the question is sort of what has the agency been hearing about the sort of telehealth flexibilities and the expansion, and what were sort of the places that we still need to look to expanding telehealth? Is that the question?
Yes.
Yeah, so we've been hearing a lot about the ability for institutions like hospitals, I believe there was a question about this earlier, to be able to bill for telehealth services. Particularly those performed by staff like therapists or social workers, etc., whose services are basically billed for by the hospital. There's currently not really a mechanism for them to furnish telehealth services and have the hospital be reimbursed, and we're working on that. We've heard a lot about, we have additional flexibility through the CARES waivers, and so we've heard a lot about expanding or waiving the portion of the statute, that restricts the practitioners that can furnish Medicare telehealth services. As you know, that list of eligible practitioners is enumerated in the statute, and notably it excludes the, certain therapists, so like the physical, occupational, speech language therapy practitioners. So we've heard a lot about expanding that list or waiving it altogether. Obviously, the audio-only phone issue and the fact that that's excluded from Medicare telehealth, we've heard a lot about that, and we're taking that very seriously because it sounds like it's a real impediment to access for a particularly vulnerable population. So I would say those are the three main issues that we've been hearing the most about.
Next question is Medicare allowing new patient visits CPT 99201 2012 99203 via telehealth.
Yes, we are.
This looks like an answer for a question before. Virtual checking applies to a lot of communication via the portal for the patients. Now they use that lot of asking about medications, what to do. They are billable. So the codes are 99441, 99442. Do we bill with site of service 11 or site of service 02? Do they need modifier?
So this is one of the aspects where this gets very confusing because there's different rules for Medicare telehealth than for these phone E&Ms. So you do not need the modifier 95 because these are not considered Medicare telehealth. You would bill with the site of service wherever it would have been furnished had it occurred in person. So if that would have been an office, if you would normally see your patients in an office, but now you're having an audio-only phone call with them and you're billing for it with these phone E&Ms, then you would use place of service 11. You do not need to use site of service 02. We're looking to promulgate some guidance to sort of clarify this, because this issue of, do I use a modifier? What technology do I need the modifier for? What technology is described by what code? What's telehealth? What's not? Like, we're hearing that there's a lot of confusion. And so we're looking to sort of promulgate some sub-regulatory guidance that will hopefully clear some of that up. I can't speak to when that's coming out because we're moving very fast, but everything is sort of kind of unpredictable right now. But we are definitely working on that. We know there's a lot of confusion.
Okay. There is another question. There are so many questions. It keeps moving so fast I can't catch it. So there is a question here. Still lots of issues in telehealth system. We were trying to use it in California for our senior mom today, but didn't work despite good internet connection. Controller was a nurse and didn't know how to operate it. So had to convert to telephone. Will she still be billed as an audio visual or audio only?
So we would consider the portion of the service, like if however many minutes, we're sort of billed via audio visual, like those could count towards a Medicare telehealth service. But if it was furnished via phone, the majority of the service was furnished via phone, then audio only phone, then that would need to be reported with the audio only codes at this time.
So the next question is, claims that were billed within the last 2 weeks with modifier CR will Medicare deny these claims? If so, will we be able to submit corrected claims with the modifier 95?
I will need this question in writing because I'm not sure. There's a lot of things been happening with the modifiers, and it's not really my area. It's more of a claims processing issue. So I would need to take this question back and try to get it sent to the right place.
So please send us the question in writing with your address and everything. We will go ahead and send it to her. She will respond to that. Okay. There is another question. In connection to previous question about telemedicine and new patient, do they allow to prescribe controlled substance to new patient using telemedicine?
That is not handled by my part of the agency. That's another one where you'll need to send it to me, and I will try to get it to the right spot.
As a physician, I would not. So. You do not give a new patient without examining them, completely doing so with a face-to-face visit. You should not give opioids on a chronic basis at least. So, okay, so any other questions? Thank you very much, and thank you for waiting and confusion created for you and for all the speakers actually. So today,
Well, thank you.
Thank you
for having me.
again. So.
All right, take care.
Okay. Our next speaker is Amit Mahajan. He spoke before, so many of you already know him. He is a neuroradiologist, but also infectious diseases specialist. So he knows on both sides of the story. And as you know, we have many radiologists practicing interventional pain management and even board certified by ASIPP. Here is Amit Mahajan.
Thank you, Dr. Manchakanti. Can you guys hear me?
Yes, sir.
Okay, thank you. Thanks for the introduction. So today we're going to be talking about the testing for COVID, and we're going to talk about the importance of testing and what are the different types of testing, so that I know if this is going to be critical going forwards as everyone is trying to go back to work or talk about going back to work, and we all understand that testing is going to be very critical to that endeavor. So why is it important is you can understand it from South Korea. Say they had around more than 10,000 cases with only around 174 to around 200 fatalities by now. And they do around 20,000 tests a day in around 633 testing sites. And they have like free drive-through testing sites with results provided by text within 24 hours. Just showing how responsive they are to rapidly testing people. And if we look at the our rate of testing as compared to the rest of the world, Switzerland is on top. This is number of tests per 1,000 people, and we are lagging behind. We are doing a lot of tests, more than 100,000 tests a day, but we're still lagging behind per the amount of population that we have. And okay, so coming to the different kind of tests we're doing, it is obviously based upon the way the infection is spreading. We all know that people are getting starts with the nasal symptoms. It is maybe the virus attaches to the back of the throat, somewhere in the nasopharynx, and then travels down the trachea, and then causing a pneumonia in the lung. And so this is nasopharynx is the most likely site of initial infection. That's why we're trying to diagnose it with using a nasopharyngeal swab. And then the oral swab is also being used for that same reason. And okay, so what test are we doing is something called the RT-PCR, also which stands for real-time reverse transcription polymerase chain reaction. And as I said, we do it on the nasopharyngeal or oropharyngeal swab, or we can also be done on a sputum sample. This is a good study on the right-hand side, which shows the, which is showing us how the titers of the virus change. This is one patient only. So the line in yellow is the nasopharyngeal swab, and the other one is the orange one is the sputum. So just showing how the secretions which are lower in the airway tend to stay positive. This lower line, this horizontal line at number 2, is the where you can it's deemed to be I mean, where it's supposed to be clinically significant, and you can see how this line keeps bouncing up and down. And you know how we have these patients who were initially tested negative and then turned out positive later on. So this is the reason why, because the PCR test shows these results which keep moving up and down a little bit. So that's why sometimes the patient may turn out negative and then a few days later may turn out positive again. And you see how the sputum has a higher level of positivity as compared to the yellow line, which is the throat swab only. And the gray line here is the line of stool shedding of the virus. Now, it's interesting that in this particular study, they could not find live virus in the stool, but they only found RNA in the stool. So they ascribed it to the fact that maybe people are swallowing their secretions in the lung and shedding it in the gut. And they also did not find any virus, any live virus in the blood in these patients. And one more finding is this upside down arrow here. That this is the point of seroconversion. This is where your antibodies start to develop, and see it's happening around the end of the first week of the illness. So as I said, this is the reason why the throat swab is only reliable in the first week, and the virus disappears in the throat, but it can still continue to multiply in the lungs, and that's why the sputum is more positive. And in the second week, it can be positive with deep airway suction or a sputum exam. Okay, so this is the example of a PCR testing system, and which detects the viral RNA, which indicates current viral infection, and it can also be used to identify contact and look for those patients who have been exposed to the virus. And this is the CDC kit on the right. This is just the chart showing you what the CDC has been doing. There's blue dots on the inferior aspect are what the CDC is testing, and this orange are the testing by the private labs that have happened after the initial snafu by the CDC labs. And this is the public health labs in orange, which have started doing the tests. And we all know what happened with the delayed rollout of the testing. I mean, UK had the testing available on January the 10th, and the WHO test was developed around January 23rd. And even Russia developed the test by February the 11th, while CDC and other private companies did not develop tests until much later. And some more. About the shedding of the virus, as I said, the pharyngeal shedding is very high in the first peak, with a peak around the 4th day. And as I said, the virus isolated from the throat and lung derived samples, but not from stool samples. And also one thing, they also found that the shedding outlasted the end of symptoms. That is why the shedding continues for a while, even after the patient gets better. Okay, this is what you do on RT-PCR. Is basically you use an enzyme called the reverse transcriptase. Basically, the virus is RNA. So what you do is, with the enzyme itself, this is the enzyme, the reverse transcriptase, you create a DNA which is complementary to the RNA of the virus, and then you multiply it multiple times in the PCR and finally test the RNA of the virus and identify it. So a couple of things, how this virus is different from the SARS virus. What people are seeing is that there is a very high pharyngeal viral shedding in the first week of illness as compared to the SARS virus. They said that the number of virus particles coming from the throat are much higher, around 1,000 times more higher than it was for SARS. And also it happens early than late. And I think this may be responsible for the asymptomatic transmission that has been happening. And also they say that because it is happening in the upper respiratory tract tissues, unlike the SARS virus, which was, it may be related to a different mechanism than just the ACE2 expression of those cells. And the question of whether we should do PCR versus radiology has been complicated. PCR is only 60% sensitive, but people feel that this may be related to sampling issues rather than rather than a problem with the PCR itself. This is the couple of X-rays and CT in patients at our institution, and you can see this peripheral opacities in the CT image, and also some hazy opacities in the lung that you can see. So the PCR is the best way of diagnosing acute infection, but chest X-ray or CT may be done if your PCR is negative and the patient still has symptoms, and you can do a repeat PCR thereafter. And this is an example of another patient who has a severe disease than the first one that we saw. Okay, now coming to the point of seroconversion. Seroconversion is the point of when the antibodies start to appear. And as I said, it happens around 6 to 12 days, and it's not associated with a rapid decline in viral load, as shown in this patient. This upside down arrow is where the antibodies have started to appear in this patient. And this is another chart from showing you 9 different patients and showing that most of them have seroconverted, except for one who did not show evidence of seroconversion. Everyone else shows that upside down arrow. Okay, a couple of more tests that are available, which I will go through. One is this antigen detection test. This is not commercially available yet. It's being produced by a Canadian company, in which if you put a drop of fluid on the side of this slide, and this red thing is the virus, it will, and you have these colloidal particles which will attach the virus and then flow along the direction of the fluid and then show up as a positive line on this virus. So this type of test basically uses detects the antigen in the secretions itself. None of the tests that we are using currently do this. So this may be a test which may be helpful in the future. They said the results will be available in 10 to 15 minutes, around $50 per this test. Other ways of testing it is so-called isothermal amplification with the Abbott test, or using the ID Now platform, which was approved around March 27th. And the other tests which are still under production is something, another one is based upon the CRISPR technology, which is being produced by Mammoth Biosciences, in which basically you send this enzyme and you cut the DNA, the RNA of the virus, and then the virus can be detected with these probes within this test tube. Again, this is not available yet, but they said that this could test it within half an hour and is as accurate as a PCR. So these are a couple of tests under production. Another antigen, I'm sorry, I don't know why it's jumping around. Okay, another test being produced in Europe, is by Bosch, Bosch in Germany, and in which they said they can detect around SARS-CoV-2 and 9 other respiratory viruses and produce results in 2.5 hours using this analyzer that they have. So what is the role of serologic testing in patients with COVID? As we all know, that it will be helpful to detect asymptomatic patients, also detect the immune status, and maybe detect people who have already been exposed, so that maybe they are ready to work while the epidemic is still going on. It may also be helpful to assess the efficacy of vaccination once the vaccine is available. And there are 70 to 90 companies who are already in the process of developing these tests. Till now, within the last 10 days, they've approved, FDA has approved 3 different tests. The first is the Select, ChemBio, and Ortho Clinical, and also this 4th test by Abbott. They've given Abbott the go-ahead to make their test without the EUA, but Abbott wants the EUA anyways. So this is the test which was used in China as well, the Select test, in which you drop a sample of blood on the part of the slide, and in 15 to 20 minutes, it will move across the slide and produce an M is the IgM, IgG, or a control line. And in China itself, they found a sensitivity of 23.8% and a specificity of 95.6% with this test. Another test was this ChemBio test, something called the DPP platform. We don't have to know why or how it happens, but this has been approved in the last 2-3 days. And the third test is the fourth test is by Abbott Labs, the COVID for the ID Now platform, which is going to be useful to look for the antibodies in patient's serum. Okay, so a couple of challenges. The coronavirus has 4 main proteins. We went through this before: S, He, Me, and the N protein. And when the antibodies are formed, they're formed against all these different components, but only those against the spike protein appear to be neutralizing. And when we are testing for these antibodies in these different testing systems, the protein that is being used to detect the antibodies has to be very specific and in the specific configuration so that the antibodies are detected on these tests. So those are a couple of challenges which I think most companies are working with right now. A couple of things to remember when you're using these serological tests. Remember that immunity to viruses and all intracellular infecting organisms is usually cell-mediated, that is by T cells and B cells, and that these And mucosal immunity is IgA mediated. So when we are measuring these antibodies in the serum, it's a surrogate for immunity. It's not those antibodies are not the cause of the immunity, but they tell us whether the person has high enough level of antibodies to prevent infection in these people. So getting a measure of the titer levels of these antibodies may also be required as we go forward. And also the coronavirus is changing as it's going by. Since the time that it started, it has developed multiple different spike protein changes over time. So we have to be cognizant of the fact that we are trying to cover all those changes in the virus with our specific antibodies. And whether protection will be achieved by vaccination is still an open question. I mean, we are still in the early stages of vaccination, and a vaccination is probably not going to be available for a few months from now. So coming back to Dr. Manchikanti's point of view, that prolonged infection cycle as it continues is going to have a grave impact on the economic, mental health, and social health of our country. So getting back to work is absolutely required, and this can only be achieved by increased testing, getting more serologic testing done, and getting more comfortable with the results of them. And ultimately, the initial hump that Dr. Manchikanti showed in the slide, it can be achieved by the decrease in infection rate that we have had recently. And following that, the availability of vaccine in the future may obviously help us to get back to work as well. So we all understand the public health impact of antibody testing. There's going to be a health worker shortage if we continue with the infection for a prolonged period of time. And so we can use this information to help our workers continue to work, as well as reopening the economy. And this is just a last slide showing how the ingenious ways people are coming with to test people in the healthcare settings. With this, I stop my talk.
Thank you, Amit. That was great. Before we go to the next session, how long does it take to develop antibodies, and how long do they stay in your blood, and do they correlate with recovery?
So that's the slide I was showing you earlier, and it takes around 9 to 10 days or 7 to 10 days for the antibodies to appear, and they do not absolutely correlate with the disappearing of the virus, but they correlate with the disappearance of symptoms.
So usually, how long do they stick around in your body?
Oh, thereafter? I mean, the SARS epidemic, when they had the people who developed the antibodies, even till now, they followed them up for 10 years, and those antibodies were still useful in neutralizing the virus. I mean, they didn't expose the patients to the virus, but they did in the lab. In vitro, they showed that the viruses could still be neutralized by their blood. So I know the older coronaviruses, they've done these tests on them in which they re-expose the people who had initial coronavirus infections and expose them 1 year later. A patient developed the infection again after 1 year. But SARS was a different thing. When they exposed their blood to the SARS virus again, the blood was able to neutralize those that virus.
So corona.
So really, we don't know what's happening.
Okay, thank you. Whoever wants to receive 2 hours of continuing education credits, watch for your emails. We will be sending you an email on Monday, and after that you can sign up, and certificates will be issued if you qualify, if you attended, I mean. Our next topic is very important. We always get the questions on various insurance issues. We want to know what happens to our business and professional life, everything apart from depression, burnout, from COVID-19 epidemic. Tom is from Willow Risk Advisors. We also have Nicole and Christina from NorCal. They are going to answer these questions in reference to the insurance issues. The first question is, do I have to pay my insurance premium?
Dr. Mangiacani, I just wanted to thank you for the opportunity to talk about this. So thank you for that. And at the end of this webinar here, I'm sure everyone is excited to talk about insurance, but hopefully we can make things a little bit easier for them. But the answer for the first question is yes, but I would call each and every one of your insurance carriers. And what we've seen, Commissioner Lana, who is in California, the insurance commissioner, actually made it mandatory for the insurance carriers out there to reimburse or to give a premium discount to car insurance, to business insurance, to your malpractice. Cuomo, New York, is trying to do something similar now. But all the carriers, and again, this whole conversation we have now, everyone should, call their individual carrier, call their individual broker, and if there's anything we can do, we're more than happy to review anything for you. But I would call your carriers in this pandemic and in unprecedented times. Most of our carriers, when our clients call, are saying, hey, we can give you a premium relief. We can extend or defer payment up until June to see what's going on. Some of the state governors, as I started to say in the very beginning, are pushing back or giving premium credits. From the home and auto perspective, we're seeing carriers, Geico, State Farm, Allstate giving money back. From the business insurance, when we look at Allstate, State Farm, CNA, Travelers, Hartford, they're more or less giving deferments or cutting down because you're based on your revenue for some of those business and general liability policies. But again, they will work with you on payment, right? Your malpractice carriers, right? Your professional liability. We've done some doctors, we've deferred payment to a certain time. We've suspended coverage because either one of the practitioners wasn't working. And sometimes we took them down to part-time and gave discounts. So again, there's things that can be worked out.
Are you trying to move the slides, Tom?
I am not touching anything.
Somebody is moving, so okay. Please don't touch the slides.
Yeah, it's getting me dizzy.
Well, yeah, I don't know where I was. So the next question was
right here.
Well, some of the members may or may not know that, but the NorCal is the ASIPP partner. We have a special program for ASIPP members with their insurance. This is not a conflict of interest. It is just the deal we offer. So what is the NorCal doing? If I have insurance with NorCal.
Yep. So I brought it back. I just moved the slides back for you, Dr. Mangiacani. Just let me, there we go. So NorCal is here. I have Christina and Nicole on the phone with us. And the question that we've been getting from a malpractice standpoint, and I'm going to let them take this in a second, is telemedicine covered by my current carrier, right? And for the most part, and not just NorCal, but we use all the major national carriers, the answer has been yes, right? But call us. Call your agent, call the insurance company to make sure, right? And the other question is, can I cross state lines? And, if you go on, there's a great website, and it's the Federation of State Medical Boards, but the government made those regulations more lax and also left it up to the individual states. But most parts, call your carrier. And I guess, Christine or Nicole, do you want to talk about some things, maybe some risk management issues about telemedicine, things to be mindful about, besides calling in to make sure it's covered?
Sure, I can take that if that's okay with you. This is Nicole, and I'm very pleased to be with you, and I do thank you for the opportunity being here. So with respect to telemedicine, so over the last many weeks, we have been fielding a number of questions regarding the risk associated with telehealth, telemedicine, especially, systems and processes that are being rushed to be put into place, in this very expedited way, of course. Some of those questions are around coverage. Is it covered? Can I see patients in other states, as Tom alluded to on his slide? Some are around logistics. What are the recommended platforms? Do we need a consent? What should it say? I mean, the questions are numerous and they're really all over the place. But in a general sort of a way, the short answer, I think, is to let your fundamental guiding light be the standard of care. Use all of those risk mitigating and patient safety tools that you would normally use, like really good, solid communication, great coordination of care, good documentation, to the very best of your ability in this given challenging circumstance that we're in. It's very different. And also, of course, with telehealth, we talked about it earlier today, is patient selection is very important. Of course, not all patients can be safely seen with a telehealth visit, and that's certainly true in your specialty. So then what are your alternatives in thinking through those things? So this is a broad topic, and I would just say, you know, for individual questions, for specific sort of questions, we would be happy to entertain those later or direct you to resources, but I think that's probably the best general answer.
Excellent. And like Dr. Mangiacani, the next question we've had some nurses, we've had some physicians, and I think Kevin alluded to in the very beginning here, are getting pulled to different departments, right? And am I covered? I'm normally, doing anesthesia and labor and delivery, and am I covered, intubating patients in the ICU? Or now I'm taking patients' temperatures outside into 10. Am I covered for that? And doctors getting pulled in all sorts of directions all over the country. And there's some risk management questions and concerns with that also. But for the most part, again, call your current carrier. But most of the carriers, and this is an all hands-on-deck situations, are going to cover that. But again, always check. And I think Nicole or Christine, if you want to jump in again here, what do we have to be concerned about if that happens?
I'm happy to jump in again. This is Nicole. I've actually fielded some of these questions myself personally. This is another common theme among the questions we've been helping folks with. We've had many physicians who have called in and expressed concerns over feeling pressured to help in ways that they're not necessarily comfortable with, right? And the answer, I think, goes back again sort of to the standard of care and proper preparation, the education, training, and current competency, et cetera, for the duties that you're being asked to perform. I think it's important, obviously, to feel comfortable with your current skills and confident in what aid you might be able to offer. And hopefully you're experiencing the fact that you have some sort of say in that. We've been very fortunate in the callers that I've talked to, at least, they have had been able to have some dialogue with the folks that they're working with. But for everyone, the collective team, just to remain mindful of the general patient safety, just as you would before, and the individual clinical care needs at hand. And again, going back to that standard of care under the circumstances. That may look a little different now because of all of our challenges, but what would a reasonable group of folks, your peers, do?
And this is Christina Cassidy. I would add to that as well in terms of your comfort and in being pulled in a different direction. And like Dr. Foe was saying, Kevin was saying, in terms of advocating for yourself and also contacting your carrier and speaking with their risk managers from their perspective or how to handle a particular situation. I think that has some value in it as well, and looking at what is your scope of practice currently, and will what you're being asked to do put you into a situation of being held to the standard of care of a completely different specialty that you don't have expertise? I think those are questions.
And it's Tom again here, and it really leads into this third point here is Dr. Mangiacani sent a great article, and I think he sent it out to everyone in ASIPP the other day, and he sent it to me too. And it actually it's based in my home state of Pennsylvania that the PBS did, that Governor Tom Wolf is putting something forward to ask the insurance carriers to give the physicians immunity for malpractice claims, right? And the one thing I want to stress to all of you out there is that, a malpractice policy is pretty simple. We promise to pay and defend you if you're named in a lawsuit. We're going to defend you, right? If the government gives you immunity, right, from the trial attorneys to sue you, great, right? And I think the plaintiff's bar is really going to fight that, but we're going to defend you anyway. We're going to defend you. You're doing your best with the standard of care. We'll see how that happens. I know New York also has a similar bill up there, and also New Jersey is leading the way. But we'll see what happens. But regardless, the carriers, for the most part, are going to defend you, whether we get immunity from the government or not. But again, you don't want to have to worry about that. And if something does happen, most carriers will stand behind you.
And Tom, if I can add to that, this is Christina again. We would, of course, recommend alongside any type of immunity or lack thereof or whatever is coming down from a statute level, that you adhere to the recommendations outlined by your local public health departments and the CDC, that you're following those guidelines, and that you ensure that both your patients and your staff are adhering to those as well. I would imagine that there could be liability, at some point down the road if it was found that there was any willful negligence. So you want to make sure that you're following the recommendations and that you're very aware of those recommendations and have implemented them in your practice as you move forward or be able to open your practices back up.
All right. Well, thank you. And Lax, I wanted to get on to the next slide, and I guess anyone else from the professional liability or malpractice standpoint during the Q&A has any questions, feel free to reach out to us at that time or even after this.
Yeah, I have a question. So what are the other watch-outs for the pain doctors to avoid malpractice suits with telehealth? What advice does Nicole have? One of the issues just brought out to me today was that if there is a lawsuit against a company because they were doing the telehealth when they were driving or something happened, and they're suing them for a huge amount. So that is, of course, we told all our employees, don't do that. So what is your advice on that, Nicole?
Dr. Mangiacotti, can you clarify for me that question? What exactly about the telehealth? Was it, do we advise to do it or at all?
It was someone driving in a... Go ahead.
Yes, go ahead. I think Tom understood my question. Go ahead.
No,
Tom.
I didn't know if you said that someone was answering a question, were they possibly driving in a car? I mean, that's what I was...
Right. This is an actual case, I think, one of our doctors sent to us saying that there was a malpractice suit because this telehealth was conducted when patient was driving or something similar to that. So
we would...
There is a liability there, so that means we should not be conducting those things in there, right? No telehealth when you are driving. So.
Well, I think that particular situation is a little bit hard to speak to. I think that from your end, from the physician's practice end, you do everything in your power. It's very, it's hard to control what the patients are doing. You would never advocate or suggest that they would attend a visit while they're mobile. Hopefully they would be at home, sheltering in place. But
right. Okay.
yeah, I mean, I don't think that we'd recommend against it. I think it goes practice by practice, specialty by specialty, your particular patient population, who you think you can serve. I know we have some pain specialists that are doing, just a variety of things. I know one locally, not too far from here, who are doing telehealth visits for check-ins and things, but are still offering procedures in their practices. But that also is, state specific. Some states have tighter, restrictions than others. So I think I would just say in general, we're not recommending against it. There's just steps to take to mitigate risks.
Right. That's correct. What I would say is that if you are doing that, patient is driving, stop on the side and then finish your visit, and after that start driving again.
Exactly. Or never start it if they're in the car. That's
right.
People never cease to amaze you, right?
So we are running out of time. You have 3 minutes. Go ahead, Tom.
Well, I can talk fast, and I switched the slide just to talk about workers' compensation. And again, we're looking at the whole breadth of insurance within a physician practice. So one of the questions we get, and I think we'll get more and more as phase 1 and phase 2 start developing, the country starts reopening, is what if one of my employees gets exposed to COVID-19? Is there coverage for that? Right? So work comp laws provide compensation for occupational disease, right, that arise out of the course of employment. But many state statutes will exclude things like, think about the flu, right? That is an ordinary disease of life. It's not something, when we're looking at coronavirus, something completely different. And for a healthcare perspective, I will say the answer is maybe yes. And again, we're going to try with all of our carriers to see how they're going to handle that. It's easy to say that a healthcare provider, on the front lines or within a physician practice may have caught COVID-19 seeing patients, and that is in their normal course of business, compared to a roofer that is on a roof and saying, hey, I got COVID-19 while I was shingling. So it's an easier scenario to get coverage there. Again, workers' comp is going to pick up after 7 days, but from what we're seeing, and we're going to see this a lot more, and it's going to change by the day, but we're going to have to check the individual policies, there will be coverage for the employees. Again, this is from our knowledge and from the policies that we read, but I would also check. But the other thing that's different, and Lax, I'll be quick, on your workers' compensation, a physician practice has always been very reasonable compared to other specialties. The one thing on the horizon, I would just watch this, because I think as claims start to develop with employees, we may see increases on the horizon there, and something to be mindful of. Next slide is, and I'm sure that you've talked about this a little bit on some of your prior webinars, but business interruption, right? And this is something we can talk about at another time, but business interruption, we all have it. It's all on our standard business policy. Unfortunately, does not cover claims associated with COVID-19. It covers direct physical loss, meaning if my office practice had a fire or wind blew out the windows or blew off the roof, that is your direct physical loss. So you would have business interruption coverage for you to continue working, and extra expense to open up another office while the office is being fixed. It's never been done. It hasn't been designed for communicable diseases, though now we're seeing New Jersey just introduced a bill. Also, New York is introducing a bill, and there's 7 other states, and nothing's been passed to try to cover this type of loss for business interruption. And this will be, in my opinion, it's almost going to go to a 9/11 type scenario where, and I don't know if any of your other insurance brokers or your policies, you see this TRIA coverage, and coverage that will prevent you or protect you from terrorism. And I think we're going to see something that is going to be government funded or government backed and offered mandatory to every provider going forward, and it'll be some sort of cooperation between the government and the insurance industry, because the insurance industry couldn't take that burden right now, and it's catastrophic for SMBs, right, and you. So we can touch on that later if anyone has any question about business interruption, and we'll see where it goes. This are some resources that are on here that NorCal put together for all different things, whether you're looking medical license board, whether you're looking for patient forms, whether you're looking for OSHA guidance. And what we did, and I spoke to Lax earlier today, is NorCal put together a 99-page document with all sort of risk management within the ASIPP practices that we're going to release early next week. That'll be on the website. Lax was reviewing it a little bit, and I think it's going through NorCal Legal. But it's a great document that Christine, Nicole, and a lot of people in the risk management department sort of help you during this COVID piece here.
Okay,
but thank you very much.
Tom.
Yeah.
There is a question for Nicole or Christina or you. Can they address liability associated with doing epidural steroids and getting COVID? As you know that epidurals reduce immunity and the risk of all the steroids, not epidurals, but it is the steroids. So there is an increased risk of COVID. I don't use steroids that much, but this is the general concept. We do use steroids. So, and some are suggesting use a very low dose of it, but I'm not sure how much difference that makes. But would insurance cover? This question comes all the time. So.
Yeah. Well. So go ahead.
I was just going to go back to the standard of care. And, NorCal does not make the standard of care. We don't create it. We would seek out, authorizing organizations or agencies that may speak to what the standard of care is, and then we will rely on that standard of care. Is that what you're referring to, Dr. Lax, just in terms of?
Yes. Well, that is the reference, but the question is everybody can find an expert on both sides, and standard of care essentially means other reasonable physicians, well-educated in your community or nationwide. So that is a simple standard, but you don't have problem covering it. Essentially, you are saying that you will cover, but if you can't find somebody says that is the standard of care, and if they can prove easily that should not be using steroids because it increases the risk, then
right.
You will
well, and the other part of that process would be that the conversation with the patient and the patient being advised of the risk, benefits, and alternatives to the treatment that's being recommended, and they go through the consent process, the informed consent process. So that would be backing it up a little bit to look at what was that process, and then if the information is conveyed and the patient feels comfortable with it, again, NorCal's not going to dictate what the standard of care is, but if there is then an adverse event that occurs and in litigation, ensues, then it may be difficult to defend if the standard of care was not met.
Thank you. We have one last question before we close. This is to Amit. It is based on your knowledge, would you recommend pre-procedure testing prior to interventional pain management procedures? This is the burning question everybody is asking about. Right now, we don't have equipment to do that, but if it is available, what is your recommendation? Since it is not available, what do you think?
This is, we're saying, are we going to do serology before doing the procedure?
Yes, that is the question.
Or are we going to do PCR?
Anything. What is your recommendation? What kind of testing do they need, or do they need one?
I think at the minimum, talking to them about the presence and absence of symptoms and exposure. But I think going forwards, if you're going to feel comfortable, I think we should insist on getting both PCR and serology. I mean, once it's available, because if they're positive on serology, then we'll be comfortable that they've already been exposed and not likely to transmit. And if the PCR is negative, then again, it'll give us a sense of confidence that everything is fine. So along with the symptoms and the both of them, I think we should push for all three of them before we start doing procedures on them. And this will be safe for us, our workers, and for the patients who follow them.
Thank you. Thank you all. It has been a long webinar, and we are very, very close to time. And have a good evening, good afternoon, good weekend. and let us move on with positive attitude towards rehabilitation, from resuscitation to rehabilitation. Thank you again. Good night.
Very good, very good. I believe that's all the time for today. On behalf of ASIPP, I'd like to thank all of our attendees for joining. We'd also like to thank our speakers for the excellent presentation. At this time, we ask that you fill out the brief survey on your screen. We appreciate your feedback as it helps us improve future webinars. This concludes today's webinar. We hope you have a great evening.